Endometrial hyperplasia refers to the abnormal proliferation of the endometrial glands, resulting in an increased gland to the stroma ratio, often due to the prolonged estrogen stimulation without the progesterone operation. Classifications by the WHO in 2014: Hyperplasia without the atypia, increased gland proliferation without the nuclear atypia, lower risk of the progression to the endometrial carcinoma. Atypical hyperplasia, intermediate intraepithelial neoplasia, increased gland proliferation with the cellular atypia, higher risk of the progression to the endometrial carcinoma up to 30%. Etiology and the risk factors: unopposed estrogen exposure. Obesity, increased peripheral conversion of androgen to the estrogen, polycystic ovary syndrome, estrogen therapy without the progesterone. Chronic anovulation, common in the PCO and the perimenopause, tamoxifen therapy, anti-estrogenic in breast but pro-estrogenic in the endometrium, nulliparity, early menarche, late menarche. Diabetes mellitus, hypertension, and the family history of the endometrial cancer. Lynch syndrome. Pathophysiology: prolonged estrogen stimulation leads to the continuous proliferation of the endometrial lining, increased the risk of the DNA replication errors, mutations, and eventually malignant transformation in the presence of the atypia. Clinical features are abdominal uterine bleeding, most common presentation. Menorrhagia, heavy menstrual bleeding. Metrorrhagia, irregular bleeding. Postmenopausal bleeding warrants immediate investigation. Infertility in the reproductive age women due to the chronic anovulation. Diagnosis: transvaginal ultrasound, increased endometrial thickness greater than 4 mm in the postmenopausal women is suspicious. Endometrial biopsy, gold standard histological assessment to differentiate the hyperplasia from the carcinoma. Hysteroscopy, direct visualization, and the biopsy if necessary. Differential diagnosis like the endometrial carcinoma, endometrial polyps, leiomyoma, submucous fibroids, and the adenomyosis. Complications like progression to the endometrial carcinoma, especially in the atypical hyperplasia, persistent abdominal bleeding, and anemia. Hyperplasia without atypia. Treatment: progestin therapy, oral methotrexate, acetate, even ergosterol releasing intrauterine system, or cyclic progesterone therapy. Regular endometrial surveillance with the repeat biopsies. Atypical hyperplasia, definite treatment: hysterectomy in the women who have completed the childbearing. Fertility sparing options: high dose progestins, but closer follow-up. Lifestyle modification: weight loss and the management of the underlying metabolic disorder like PCOS and the diabetes. Endometrial hyperplasia is caused by the prolonged unexposed estrogen stimulation, obesity, PCOS, tamoxifen use, and estrogen therapy. Here are the key risk factors. World Health Organization in 2014 classification divides the endometrial hyperplasia into two types: without atypia and with atypia. Atypical hyperplasia has up to 30% of risk of progressing to the endometrial carcinoma. Abnormal uterine bleeding is the most common clinical presentation. Transvaginal ultrasound shows the endometrial thickening greater than 4 mm in the postmenopausal women. Endometrial biopsy is the gold standard for the diagnosis. Progestin therapy is the mainstay for the hyperplasia without the atypia. Hysterectomy is recommended for the atypical hyperplasia in women not desiring the fertility. Even ergosterol releasing losa is highly effective in treating the endometrial hyperplasia. Tamoxifen increases the endometrial hyperplasia risk due to its agonist effect on the endometrium. Endometrial carcinoma risk is higher in the atypical hyperplasia compared to the non-atypical forms. PCOS is a common cause of the endometrial hyperplasia due to the chronic anovulation. Hysteroscopy allows the direct visualization and the biopsy for the definitive diagnosis. Weight loss and the management of the metabolic syndrome can reduce the risk of the hyperplasia recurrence. Frequent endometrial surveillance is essential during the progestin treatment.